Fail to try, okay? Don't stop to try, okay? So you should try attempting each and every spotter. No matter whether it is right or wrong, don't focus on it. Just focus on attempting it, okay? So ready for the first spotter? Here is your first spotter. I want all of you to type in the answers in chat box.
We will flash it for 30 seconds.
Yeah. Every slide will be there for 30 seconds and you should answer within that time. Okay, I'm already seeing the answers. Very good. The answer is first who has replied? Raghunath. Very good. It's intersusception. All others also have attempted. Few have typed scleroderma, stack of coins, and most of them have typed the right answer, intersusception. Good. How
Can move
did
to
you
the
say that it is intersusception? What is the sign you are seeing here? What is the sign? Coil spring sign. Very good. Who? Fatima. Very good. This is coil spring sign. So let's go for the answers. So this is coil spring sign seen in intersusception, where there is contrast is seen outlining the trapped mucosal folds. This indicates jejunal intersusception. It is seen in infants and young children with acute abdomen. Diagnosis is very important, otherwise it will go for ischemia and perforation. We don't want to happen. So we don't want ischemia to happen. So we want to diagnose it as early as possible. Okay. Yeah, I'll tell you how to differentiate from scleroderma. Next spotter. Yeah, Priyam, right answer. This is scleroderma. Now I think you can only, yeah, this is hidebound sign. Hidebound sign. Seen is scleroderma. Very good. I can see so many of the students answering right and many others attempting it. Very good. So this is hidebound sign seen in scleroderma. Here we can see the saculations or pseudodiverticula. Someone asked, how do we differentiate between this coiled spring sign and hidebound sign? See, in hidebound sign, what we see is the pseudodiverticular sacculation type. This is wide-based pseudodiverticular kind of appearance, which we see in case of scleroderma. Whereas in coiled spring, here we can see that this contrast is entrapped within the mucosa. Okay, here we are not seeing any pseudo diverticular type or sacculation type of things. Okay, here this is basically the mucosal folds which are being enhanced with the contrast. This is the entrapped mucosa being enhanced with barium. So that this is coil spring. Whereas here we can see that there are sacculations or pseudo diverticulae which are seen in scleroderma. Have anyone wondered why is this hidebound sign? What is the meaning of hidebound sign? Hidebound means what? So hidebound is nothing but when the skin is tightly attached to the underlying flesh, like we see in malnourished animals or patients, where we'll be able to count the ribs also beneath. So that is hidebound, and that's how here it is seen. So the name hidebound sign. I hope I am clear now. And what are the other features in scleroderma? There will be jejunal dilatation, there will be decreased motility and delayed transit. It is classic for systemic sclerosis involving GI tract. Okay, we'll go to the next spotter now. Here is the next spotter. Come on, students, start attempting it. Pneumatosis intestinalis is correct, but there is one more black arrow mark. So put both of them together and come to a conclusion. What could this be? Yes, all of you are answering, but in parts. I want the final answer. Yes, someone has answered correctly. Let me see who is this. Yes, Harshit has answered correctly. Many of you all have answered, but in parts. So for the final diagnosis is bowel ischemia. How did you come to the conclusion of bowel ischemia? The white arrow mark here is showing the intramural gas. It means there is gas within the bowel wall because it is seen in the dependent as well as non-dependent aspect, which indicates that this is an intramural gas and not intraluminal. And here, what does this black arrow mark point to? This is liver. Okay, this is hypodense thing in the liver that is air. So there is air in the liver. So if it is air in the liver, there can be two things. Air can be in the portal vein or it can be in the biliary structures, that is pneumobilia. Now, how do we differentiate between portal venous gas and pneumobilia? Come on, students, I want the answers. Yes, peripheral is portal venous gas. How do I remember? P for P, portal vein, periphery. Yeah, so this is portal venous gas, and here we have intramural gas. So both of them put together, it is bowel ischemia. Very good. So white arrow is pneumatosis intestinalis, gas within the bowel wall, and black arrow was hepatic portal venous gas, which is an ominous sign. So it basically suggests bowel ischemia or infarction. It is an emergency condition, so it needs urgent surgical intervention. Okay, so let's go to next one. What could be the age of the patient? What is the investigation? And what is the sign you are seeing? And what is the condition causing it? Pediatric patient, correct? Yes, Purbita. Purbita answered it correctly. Very good. This is meconium ileus. How did you come to this conclusion that this is meconium ileus? First of all, it's a pediatric. Okay, one more question I have. This is seen in which condition? Commonly seen in which condition? Yes, CF, cystic fibrosis. Very good, very good. Who answered it first? Vrinda. Vrinda answered it first. Very good. This is seen in cystic fibrosis. So this is if for the students who are not getting anything from this, you go stepwise. Okay. What age of the patient? This is pediatric patient. So we have to consider the conditions which are seen only in pediatric patients. Okay. Okay. Then what is the part image here? This is abdomen. This is radiograph of abdomen. What are we seeing here? This is the mottled appearance or soap bubble sign. Why is this sign seen? Because here the meconium is admixed with the bowel gas. So which is giving rise to mottled or soap bubble appearance. Where it is seen? It is seen in meconium ileus, where the meconium is not being passed. So it is getting retained in the bowel, getting admixed with the bowel gas, giving rise to this soap bubble appearance, and it is seen in cystic fibrosis. So this radiograph shows marked small bowel distension, soap bubble sign, as I already told, it is seen in cystic fibrosis. It presents in neonates with abdominal distension and failure to pass meconium. Okay, the next spotter. Very good. I can already see the answer. So try to type completely, okay? Someone has typed ileal atresia and someone has typed microcolon. Can I get a combined final answer? Yes, it's ileal atresia with microcolon. How are you? Why are you saying that? Here, what is this study? This is barium study. Okay, barium study where we can see that the colon is ribbon-like appearance. Colon is showing ribbon-like appearance, and there is dilatation of the ileal lobes. So there is congenital distal ileal atresia, because of which the colon is not being used. So it is showing ribbon-like appearance. So it is microcolon. So it's a thin ribbon-like microcolon due to unused colon. Proximally, there are markedly dilated small bowel loops up to lower ileum. Classic finding in congenital ileal atresia. It presents in neonates with abdominal distension and failure to pass meconium. Okay. Next spotter. Yes, no secretions from ileum, so colon is micro. Yes, Aishi, right answer. This is endometriosis. How did you say it as endometriosis? This is again the barium study where we can see that there is something infiltrating from outside. Yeah, from here also in this region and in this region. And also there is an ureteric stent here, DJ stent. So there might be involvement of ureter also. So this is a case of pelvic endometriosis. It is double contrast barium study, shows speculations and mucosal indentations of
Ma'am,
rectal
can you
flora.
please repeat this?
Repeat what?
Ma'am, this spotter
Yeah,
endometrium.
yeah, yeah. Have a look at this. It is not ischemic colitis because here the in ischemic colitis the pathology per se will be in the bowel wall and it won't be something from the outside. But here, by the way it is involving, we can make out that the pathology is outside the bowel and not within the bowel wall. Yeah, it can be any other mass lesion also. Here we are considering endometriosis as a DD. Okay, let's go to the next one. Kapil, I think we'll wait for 30 seconds so that everyone will get to see the slides properly.
Yes, ma'am.
And
Yes,
then
ma'am.
we'll. Yeah. You just tell me when the 30 seconds are up and then I'll start discussing the answers.
Sure, ma'am. Done, ma'am.
Done?
Yes, ma'am. 30 seconds.
Yes. Okay. Yes, many of you have answered it correctly. It is gallstone ileus. Regular sign. Okay. Very good. So it's gallstone ileus. Why gallstone ileus? Here we can see that there is air in the liver, that too in the central part. So this is pneumobilia. Okay. And there are dilated ileal loops, dilated bubble loops. So it is gallstone ileus. Regular is there'll be dilated small bowel loops, there'll be air in the biliary tree. It's commonly seen in elderly females. And when we have all these three things, that is pneumobilia, small bowel obstruction, and ectopic gallstones, it is called Rigler's triad. And the most common site of impaction is ileocecal junction. Okay. Next spotter.
We'll wait for 30 seconds.
Yeah. Description is given. This is of 72-year-old female with gastric adenocarcinoma, so that you will get some clue.
Done, ma'am.
Okay, time is up. Yes, many of you have answered it correctly. It is omental caking. Priyam Sharma has answered first. This is omental caking. Very good. Where is the omental caking? Here. Omental fat should be seen like this as any other mesenteric fat. It has to be hypodense. Whereas here, the fat is not appearing hypodense. Instead, it is appearing hyperdense. So there is caking of the omentum. It represents metastatic infiltration from here in this patient from gastric adenocarcinoma. It can also be seen in CA colon, ovary, pancreas, and stomach. It is seen anterior to the transverse colon, and omentum is often obliterated by the tumor. Someone has asked to show the stone. In this radiograph, it is not seen. Maybe it is small and we are not able to see on radiograph. Or maybe it is radiolucent also. But the other two things of the triad we are able to see here. So we can just write gallstone ileus rather than regular triad for this. Just for the discussion, I discussed regular triad also. I hope I'm clear with that. We'll go to next spotter. Start the timer.
Yes, ma'am. Already.
Yeah.
Timer is up.
Okay. Again, Priyam Sharma has answered it first. Many of you all have answered it correctly. Very good. It's ascariasis. How did you say it as ascariasis? Here we can say there is a linear filling defect, and within that filling defect also we are able to see a linear contrast. So that is the contrast within the lumen of the worm. Okay, so this is intestinal ascariasis. It's barium follow through, which shows a linear filling defect within the normal loops. And then there's central barium line also. There's no mucosal abnormality or obstruction. It is caused by infestation with Ascaris lumbricoids. It's common in tropical regions and pediatric populations. Okay, let's go to the next spotter now.
Timer is start.
Oh.
Timer is up.
Okay. Jaideep has answered it first. Very good. Many of you have answered it correctly. This is xanthogranulomatous cholecystitis. How do you say it as cholecystitis? Because here on CT we are able to say we are able to see that this is a thickened gallbladder wall, and there are multiple intramural hypodense here and hypoechoic here nodules within the wall of the gallbladder. This can be a potential DD for carcinoma also. So there's marked gallbladder wall thickening with intramural nodules, as I showed you. It mimics gallbladder carcinoma radiologically. This is basically due to chronic inflammatory process with lipid-laden macrophages. Okay, let's go to the next spotter now. Your timer is started.
Timer starts. Yes, ma'am. Up, ma'am. Timer up.
Timer? Yeah. Raghunath has answered it first, and many of you all have answered it correctly and also attempted. Very good. This is pseudolipoma of Gleason's capsule. Why do you say this as pseudolipoma? This is showing hypodense area here. It represents herniation of peritoneal fat through a defect and it's often incidental. On CT, there'll be fat attenuation lesion at the surface. It won't show any enhancement. It's very important to differentiate this from subcapsular liposarcoma or metastasis, in which case it will be enhancing and heterogeneous. If it's only Glissen's capsule pseudolipoma, no treatment needed unless it's symptomatic. Timer starts now.
Time is up, ma'am.
Okay. Okay. Again, Raghunath has answered it first. This is ileosis hepatis. Others also have attempted. Very good. This is not focal fatty infiltration, because if it's focal fatty infiltration, it won't appear like this, and it won't show enhancing areas like this. So it's basically ileosis hepatis is blood fluid cystic spaces. It's associated with anabolic steroids, oral contraceptives, CT imaging findings, as we saw. It's the multiple irregular low attenuation lesions, and important thing is it does not cause any mass effect unlike other masses. It might show delayed enhancement. So differential diagnosis includes metastasis, abscess, or hemangioma. It may be asymptomatic or present with rupture. Biopsy confirms the diagnosis.
Timer starts.
Okay.
Time is up.
Yes. Sohan, many of you have answered, but Sohan has answered it completely. It's mediastinal pseudocyst with chronic calcific pancreatitis. This is pseudocyst because here we can see that there is a cystic lesion in the posterior mediastinum, and when we see the abdomen sections, here we can see that there is chronic calcific pancreatitis, also pancreatic pseudocyst. So when we correlate both these findings, we come to a conclusion that this is a mediastinal pseudocyst with the background of chronic calcific pancreatitis. So it is the extension of pancreatic pseudocyst into the posterior mediastinum. CT findings are well-defined unilocular or multilocular fluid density lesion. There won't be any solid components or enhancing component. It's often asymptomatic, may present with abdominal mass or discomfort. Management will be surgical excision. Next, Potter.
Timer starts now. Time's up.
Okay. Sahiti has answered it first. This is emphysematous. Jaydeep has answered it completely. This is emphysematous pancreatitis. Why? Because here in the region of pancreas, we are seeing multiple air foci. So it is emphysematous pancreatitis. Someone has answered question. Why not stomach herniation? This is not stomach herniation because already we are able to see that the pancreas is showing pseudocyst. So it's more likely obviously when we see the continuous sections, we'll be able to say with confidence. But when we are given the sections like this, there should be some reason, right? So when the pancreas is showing pseudocyst, we should correlate that with this lesion rather than the herniation of stomach. Okay. We were discussing this case. There are multiple locules of air within and also around the pancreas. It suggests infection with gas forming organisms. It is associated with necrotizing pancreatitis. It's an emergency condition and requires prompt intervention.
Timer starts now.
Next portal.
Time is up.
Okay. Purvita has answered it correctly. I think because of the in a hurry to answer it first, only short forms are coming. Okay, so this is emphysematous cholecystitis only. Here this is a radiograph where we are seeing the lucency, which is outlining the gallbladder. So this is basically the intramural air within the gallbladder, which is suggestive of emphysematous cholecystitis. This is radiolucent gas seen outlining the gallbladder. It is caused by gas forming organisms, more common in diabetics and elderly. It's a surgical emergency. Okay. Next portal.
Time starts. Time is up.
Okay. Nashreen has answered it correctly. It's biliary cystadenoma. Many of you have all typed hydatid also. Let's discuss it later. Why this is not hydatid, and this can be hydatid also, but why in this case you have to type biliary cystadenoma rather than hydatid. So now with this case, the discussion is biliary cystadenoma is multiloculated cystic lesion with thin septations in the liver. It typically shows internal septal enhancement on post-contrast imaging. It's seen in middle-aged women and it has pre-malignant potential. So whenever this is diagnosed, it requires surgical excision. Next portal.
Time starts. Time is up.
Okay. Yes. Now this is hydatid cyst. There is well-defined cystic lesion with internal daughter cyst giving rise to water lily sign or rosette sign. See, in this condition, in this slide, you have to focus on this rosette sign or the water lily sign. Whereas in the previous slide, it was multiloculated cyst. No doubt that hydatid cyst also can be seen like this. But in spotters, usually we look for the classic signs. So here, this rosette sign is a classic sign for hydatid cyst. So whenever you see like this, you have to answer it as hydatid cyst. And whenever you see a multiloculated cystic lesion, you have to answer it as biliary cystadenoma. It is caused by Echinococcus granulosus and it commonly involves liver, can calcify or rupture. Okay. So whenever it involves a lung, what is the typical finding in a hydatid cyst in a lung, pulmonary hydatid you see? Yes, very good, Priyam. It doesn't calcify. Why? Why does not? Why it does not calcify? Continuous movement, yeah, that is also One of the cause. Yes, very good. Vrinda and Anushka, very good. Because of less carbon dioxide and constant motion, the calcium will not precipitate. So there won't be any calcification in the pulmonary hydatid.
Time starts. Time's up.
Surasini has answered it first. It is bifid tail of pancreas. Purvita has also answered, but half bifid pancreas. Yes, this is bifid tail of pancreas. What is the importance? This should not be mistaken for any mass lesion in the pancreas. It's congenital anatomical variant where the pancreatic tail splits into two branches. It is best seen on MRI or CT, usually asymptomatic and no clinical intervention typically required.
Time
Next
starts.
quarter.
Time is up.
Okay. Okay, many of you have answered. Sahitya has answered first. Yes, this is pancreatic lipomatosis or fatty infiltration of pancreas. We can see that there is hypodensity in the region of pancreas. So, pancreas appears hypodense relative to liver due to fat infiltration. It's commonly seen in obesity, diabetics. This homogeneous low attenuation without any mass effect. Without any mass effect is important. If it's causing any mass effect, then we have to think of fat forming mass lesions. It's important to differentiate from pancreatic neoplasms, usually incidental and asymptomatic. Next, Potter.
Time starts. Time is up.
Okay. Yes, the answer is bilateral grade 5 VUR. Purvita has answered, but not completely. Aditya has answered it completely. It's bilateral grade 5 vesico-ureteric reflux. We have grading, right? So, what are the grades of what is grade 1 reflux into? Start typing. Where will the reflux be in grade 1? Into ureter. Very good. Grade 2, pelvic system. Very good. And in grade 3, whether there is mild, moderate, or severe dilatation of ureter, mild dilatation. Okay, grade 4 is moderate dilatation. Whether the papillary impressions will be preserved or not, type yes or no. Yes, yes, very good. Preserved papillary impressions. And in grade 5, yeah, grade 5, there will be loss in papillary impressions. So this is the grading we discussed just now. And on imaging, we can see that contrast outlines a grossly dilated tortuous ureter in the slide which we have seen. And there will be there was pelvic system contrast opacification also. There was loss of papillary impressions, which is consistent with grade 5 UR. It is related to abnormal VUJ vesico-ureteric junction development. Okay, next Potter.
Time starts now. Time is up.
Okay, Anushri has answered it correctly first. This is striated nephrogram. Yeah, the answer can also be pyelonephritis, but pyelonephritis is one of the causes leading to the striated nephrogram. So here the right answer has to be striated nephrogram rather than pyelonephritis. Okay, why do we call it as for the other students? Why are we calling it as striated nephrogram? Because here on we are seeing the linear hypodensities. This is not how a normal nephrogram is supposed to be. Here we should be seeing uniform hyperdensity or uniform enhancement of the cortex. But here instead we are seeing the linear hypodensities in between, giving the striated appearance or striations. So this is called striated nephrogram, where there will be radial bands of alternating enhancement. Here, bilateral striated nephrogram pattern. Causes are so many, including acute pyelonephritis, ATN, ARPKD, hypotension. It could be either due to altered perfusion or tubular flow. There are different causes of unilateral and bilateral striated nephrogram. Unilateral might be due to ureteric obstruction, pyelonephritis, renal vein thrombosis. Bilateral could be due to ARPKD, pyelonephritis, acute tubular obstruction, etc. Okay. Next spotter.
Time starts now. Time is up.
Okay, Sarojini has answered it first. It's a melangiomyolipoma. But when you are writing the answers in the exam, please write it completely. Okay, I understand that you are all in a hurry to type it first here so that your name comes up. But when you're writing in the exam, it should be a complete answer. Okay, this should be angiomyolipoma of left kidney with Wunderlich syndrome. Why are we saying it as Wunderlich syndrome? Because there is retroperitoneal perinephric hematoma, which is due to a lesion which is showing fat density, soft tissue density, as well as enhancing vessel-like density. That is, this is pseudoaneurysm component of the angiomyolipoma. Angiomyolipoma means angio means blood vessel, myo means muscle, soft tissue, lipoma means for fat. So all these three components will be there in angiomyolipoma, and when that pseudoaneurysm ruptures, that leads to perinephric or retroperitoneal hematoma, which is seen here. So it's well-defined left renal lesion with fat, soft tissue and vascular components. And if the lesion size is more than 4 cm, then there will be increased bleeding risk. There will be microaneurysm rupture leading to the hemorrhage and hematoma. This is classic for Wunderlich syndrome. Okay.
Time starts now.
Next spotter.
Time is up.
Okay. Sahiti has answered it correctly. It's retroperitoneal fibrosis. Why are we saying it as retroperitoneal fibrosis? There is medialization of ureter, and this is called maiden waist sign. Someone has typed the sign also, very good. So it's maiden waist sign, medialization of ureter, and there is dilatation of right proximal ureter and pelvic ileus system also. Left also mild dilatation of left ureter is there, but pelvic ileus system is calyceal system is not dilated. So, classic triad is there will be medial deviation of mid ureters, there will be smooth tapering of one or both the ureters, and there will be proximal unilateral or bilateral hydroureter nephrosis with delayed contrast excretion. This is due to fibrotic entrapment of ureters in the retroperitoneum. Next spotter.
Time starts. Time is up.
Okay. Zuleika has answered it correctly. This is retrocaval ureter. Why retrocaval ureter? Because we are seeing there is proximal hydroureter nephrosis on right side, and there is here on correlation with CT imaging, we are seeing that the ureter is going posterior to the IVC. Okay, I have a question for you all now. Is this the anomaly of developmental anomaly related to ureter or IVC? Yes, this is IVC abnormality. Sahiti, correct. Someone has typed the type of retrocaval ureter also. This type 1, very good. So it's a developmental anomaly of IVC and it is not of ureteric origin, where the proximal ureter passes posterior to IVC and loops anteriorly. Type 1, which is the commonest type, S-shaped or fish hook deformity of the ureter with moderate to severe hydronephrosis, whereas in type 2 there will be only mild medial deviation with little or no hydronephrosis. It is diagnosed with IVU or CT urography. Next spotter.
Time starts now.
No, there's no papillary necrosis in that patient. And someone had typed retrocaval ureter for the previous patient, previous slide. Now I think that doubt is cleared why that is not retrocaval ureter.
Time is up.
Okay. Renal hypomatosis. Very good, very good. Purvita has answered it correctly. This is renal replacement lipomatosis, and also there's a calculus here. Why renal replacement lipomatosis? Here we are hardly seeing any parenchyma left. It's all replaced by the fatty tissue. So this is renal replacement lipomatosis, and there's a hyperdense content here, that is calculus, Stagon calculus. Here CT shows enlarged renal sinus with fat density replacing the renal parenchyma, associated renal parenchymal atrophy and central Stagon calculus. There is strong link with chronic calculus disease and chronic inflammation. Differential includes xanthogranulomatous pyelonephritis, but what is the sign we see in xanthogranulomatous pyelonephritis? Yes, it's bare paw sign. So this is not xanthogranulomatous. Usually the typical signs only we have to pick in the spotters. The next spotter.
Time starts. Time is up.
Okay, Satvik has answered it correctly. This is renal lymphangectasia. CT shows slow attenuation perinephric and parapelvic fluid collections. There is no renal parenchymal mass or significant enhancement abnormality. Will be associated peripelvic cyst, retroperitoneal fluid, and possible ascites also. Medulla spread is also there. Poor corticomedullary differentiation on ultrasound. And confirmation is only with chylous fluid aspiration. Next spotter.
Time starts now. Time is up.
Okay. Yes, Purvita, this is phlebolith only, but phlebolith of where? Yes, Deepu, correct. It is varicocele calcification. Basically, it is the phlebolith of pampiniform venous plexus. So there are multiple small round calcifications in the pelvis along the expected course of pampiniform plexus. Phlebolysis are nothing but calcified venous thrombi. These are seen in long-standing varicocele, and this is an important mimic of distal ureteric stones. So, how do we differentiate if it is not here and if it's somewhere here? How do you differentiate between the phlebolith and ureteric calculus? There are two signs, right? So, what is the sign for phlebolith? On CT. Sign for phlebolith on CT. Rim sign is for what? Yes, Vrinda, correct. Comet tail sign is for phlebolith on CT. And for ureteric calculus? Yes, soft tissue rim sign. Soft tissue rim sign for ureteric calculus. And who said this? Vrinda only again. Very good. So soft tissue rim sign is for ureteric calculus, and for phlebolith it is comet tail sign. Someone asked, why can't this be calcification of sebaceous cyst? Yeah, this can also be a sebaceous. Where is that question? Scrotal sebaceous cyst also, but the possibility of this being pampiniform plexus calcification is more likely than sebaceous cyst. So that is this phlebolith of pampiniform plexus is more common than the sebaceous cyst here. So we go with pampiniform plexus calcification. Next, Potter.
Starts now. Time is up.
Okay. This is, yes, who has answered? Alicia has answered it correctly. Very good. This is transplant kidney with lymphocele. No doubt, kidney is seen in right iliac fossa. It's a transplanted kidney, so it is seen in right iliac fossa, and we are seeing the hypodense collection over here, which is lymphocele. It's well-defined hypodense collection in pelvic region adjacent to the transplanted kidney. It's most common. It is common post-surgical complication due to lymphatic disruption. It might cause graft compression and ureteric obstruction. It typically appears 1 to 3 months post-transplant, and it is confirmed by imaging and aspiration. Next, Potter. Look at the age of the age of the baby, so that you might get some idea. Can someone think anything else than Wilms tumor?
Time is up.
Yes, Dr. Amir has answered it correctly. It's mesoblastic nephroma. So it's large solid renal mass in a neonate seen on CT as well-defined and heterogeneously enhancing. It's most common renal tumor in neonates, typically diagnosed around 3 months. It often mimics Wilms tumor, so many of you have answered it as Wilms tumor only. Imaging differentiation is definitely unreliable, and surgical excision is necessary for confirmation and treatment. So in these cases, it's better to write both of them as Dr. Amir wrote. Yes, that was the last Potter. Thank you all. You all participated very actively. Thank you so much.
Thank you, ma'am, for this wonderful spotter session. And I hope all the residents must have gained significant insights into the new spotters, which they were not aware. And I request all the residents to actively participate in these sessions. We will be conducting similar sessions on weekends regularly. And I also request all the residents to write one answer daily on the group which we have created. It will help you definitely in the final exam when you panic a lot key how to complete the syllabus in a short span of time. So it's better to start writing at least one answer daily, especially the second year and the final year residents. And gradually you will improve the art of writing a perfect kind of answer, because the what you do in the final exam will depend on lot what you do in the previous 3 years before the exam. So I wish best of luck to all the residents, and thank you, ma'am, once again for this wonderful session. I think we
Thanks a
can
lot.
conclude the session now, ma'am.
Yeah, we can wind up. Thank you.
Thank you, ma'am.